Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hello, welcome to special conference coverage from the 2026 Elevate-Derm RAPIDS Conference. I'm Victoria Garcia Albea. I'm a dermatology nurse practitioner. I practice at a hospital called Leahy Clinic outside of Boston, Massachusetts. And I am here with the phenomenal Dr. Lisa Swanson, who just got off the stage talking about all things JAKs and immunodermatology. So let's kick it off with a discussion about the shingles vaccine
Yeah.
and patients who you might be considering an oral JAK inhibitor for.
Definitely. No, it's a good question because we know that the risk of having cold sore virus or the shingles virus and chickenpox VZV go up when you're on an oral JAK inhibitor. And who is eligible for a shingles vaccine? So the guidelines say that if you're 50 and up or 19 and up on an immunosuppressing medication, then you're eligible for the vaccination. And an oral JAK inhibitor counts for insurance purposes in order to get them vaccinated. I, for one, cannot wait to get the shingles shot because they are showing evidence that it helps reduce dementia risk, and I'm all about that. And so I'm 47, so in 3 short years, I can get my jab of the shingles shot. I can't wait. It's an important thing to talk to families about, patients and families about, because there is an increased risk. Now, in my pediatric space, if you're thinking about using an oral JAK in like a 12 to 17-year-old with alopecia areata or with atopic dermatitis, they are less than the age that the shingles vaccine is indicated for. So what do you tell them? What I tell them is that it is possible, even without being on a medication, for a child or a teenager to get shingles. We see this these days. Kids and teens with completely normal immune systems get shingles sometimes.
Even if they've had the chickenpox vaccination.
Yes. So we actually started noticing this trend once the chickenpox vaccine was more well used. And there are a couple theories as to why this is. One is that the vaccine provides a different level of immunity than actually having the chickenpox, and so your threshold of reactivation is lower. The other theory is that there's less VZV just kind of floating around in the world because of chickenpox vaccination and shingles vaccination. And so we're not getting our immune system boosted intermittently by interacting with those viruses. And so our defenses get down and we get the shingles. Interestingly enough, though, in kids, shingles doesn't hurt. It either itches or is asymptomatic.
Does it look the same as regular, typical shingles that we would picture in an elderly person?
It does look the same, although I would say that it is less prominent blisters, more like dermatomal erythema, sometimes with these like kind of deeper red papules, but it's the pattern that really sets it apart.
So it sounds like you've diagnosed it quite a bit in kids.
Yes.
Are there any demographics, like an age group or like a distribution? You know how it's most commonly truncal in adults? Is that still true for kids?
No, it seems like it could. I mean, and this is just my anecdotal experience, but I feel like I can see shingles almost anywhere on a kiddo. I can even picture in my brain, pictures of patients that I used in my presentations, and there doesn't seem to be really any particular location. But it's the presentation. Often the kids feel sick, like they don't feel themselves. They might be tired, so they experience the virus in that way too.
I feel like this is something that we could have missed. Do you think there are associated postherpetic neuralgias that kids suffer from if we've missed it?
I think if you've missed it, I think sometimes it gets misdiagnosed as allergic contact dermatitis is what I see it misdiagnosed most commonly as. They're like, "Oh, you got this weird streak of something on you," and it
Outside
caused
job.
yes,
Yeah.
yes, and it caused this rash. The unilaterality of it is something that should alert our brains, like, could this be shingles? Because shingles in kids is not painful. I've actually never had a kiddo report pain, just asymptomatic or itchiness. I have never seen a kiddo with postherpetic neuralgia or even like postherpetic pruritus. It seems to kind of come and go. I treat it when I see it,
Okay.
but if you've missed it, chances are that child got better anyway. I think the biggest, most important thing is that you can't catch shingles from shingles, but you can catch chickenpox from shingles. And so a person with shingles needs to be kept away from a pregnant woman or a baby under the age of 1 because the first chickenpox vaccination is given between the ages of 1 and 2. So that would be probably the biggest potential badness that could happen from missing shingles is if that child happened to interact with a little teeny baby or a pregnant woman. That would be the only hardship there.
Okay, last question on this topic. Have you had kids under 19 get the shingles vaccine?
No.
Okay,
No.
easy
I
answer.
I I think that would be hard insurance-wise to push that through, and let me also say, just in case it wasn't clear, the shingles that I've seen in kids have been in patients with perfectly competent immune
Mm,
systems. None of my patients on an oral JAK has gotten shingles.
interesting.
I do believe that that risk is there, and the data clearly shows, and it's dose dependent. So we know the JAKs increase the risk of reactivation of VZV. We know that. But all the patients to date that I've seen with shingles, they just got shingles. They weren't on any medicine that put them at risk.
Okay.
Yeah.
Tell me about your successes using Polypodium leukotomus, aka HelioCare,
Yeah.
in your vitiligo patients.
I love HelioCare for so many things. So it protects your skin from the sun. So it works really, really great for sun sensitive conditions like polymorphous light eruption, solar urticaria, dermatomyositis, cutaneous lupus. Works the best thing I've ever seen for those conditions, honestly. And anybody of any age can take it. They take it in the morning. The capsules are big, but they can be opened up and the powder can be sprinkled on food or in juice. I have a lot of patients add it to orange juice in the morning. I routinely, and by routinely, I mean every single time, recommend HelioCare when I am treating with topical ruxolitinib for vitiligo because we know it's interesting that polypodium leukotomas protects your skin from the sun. Counterintuitively, it makes light therapy work better for things like psoriasis and vitiligo. Studies have shown if you're in the midst of narrowband UVB for psoriasis or vitiligo, the patients who are also on HelioCare do better. It potentiates that light benefit. So we know that topical Rux works better in sun exposed areas, and sun works better with HelioCare. So I build on those betters. And whenever I'm treating vitiligo with topical Rux, or even if a patient has more extensive vitiligo and I'm opting to use an oral jack off label, I'm always recommending HelioCare with it.
Okay. And it's over the counter.
Over the counter, you can buy it on Amazon year round. Some pharmacies, some drugstores will have it in the summer,
Mm,
but they don't have it in the winter.
okay.
And so I encourage my patients to buy it on Amazon where they can get it year round.
And same dose
Same
for all
dose.
ages.
Yeah, same dose, 1 pill
One.
a day.
Okay.
Yeah, and families love that it's natural. It's based in a fern leaf extract from South and Central America. They love that story. And it's been around for centuries. You know, natives used it for years and years and years to protect themselves from the sun, and they thought it had other powers and properties too. So it's something that's existed for a long, long time.
Is it available as a topical?
It's interesting you asked that. I recently had a patient come in who had purchased a cream in Europe that was promised to help vitiligo and protect from the sun. She brought it in to ask me if it was okay to use it. And I'm looking at it and it's got polypodium leukotomas in it. And I was like, oh, that's fascinating. Now, I don't know if topical use has really been validated to have the same potential benefits. I don't know where this was manufactured. It is the brand name HelioCare that has been studied in all the studies to date looking at polypodium leukotomas and its various properties. So I feel more comfortable sticking with that. But it seems like in some places we might see polypodium leukotomas available in topicals.
Okay.
I wouldn't trust it enough to recommend
Yeah.
it at this point.
I feel like we would have it if it was a thing.
Right? Yeah,
Wouldn't
yeah,
already have it by now.
yeah, yeah, yeah.
All right. So let's say you have a patient on topical ruxolitinib for vitiligo and they repigment 100%. Everybody's over the moon.
Mhm.
What is your protocol for long-term treatment? Do you keep them on ruxolitinib? Is it still the same BID dosing? Do you switch them to like some alternative? What do you do?
I think this is an evolving topic and evolving conversation. And how I feel about it today will probably differ 6 months from now, a year from now, 2 years from now. In the studies of topical Rux for vitiligo, they had the patients keep using it. And when they did keep using it twice a day, they saw very little recurrence. In real life, some patients might not want to keep using it twice a day forever and ever and
They
ever.
lose motivation.
They lose motivation. The pigment is back. They think, what's the point? We know that when you stop it after achieving success, that there is a percentage of patients that will have recurrence. And most studies quote something around a 30% chance of recurrence.
Okay.
We also know from some previously done studies that if you use tacrolimus topically twice a day, 2 days a week, it reduces that risk of recurrence to 10%.
That's like stopping their ruxolitinib.
Stopping the
switching
Rux.
to tacrolimus twice a week.
Yes.
Okay.
Twice a day, 2 days a week.
Oh, sorry, twice a day.
Yes, yes. And so I've often had my patients do that. However, there are studies in progress where they're looking at ruxolitinib twice a day until you have repigmentation and then some degree of maintenance therapy. So I imagine in the future, we'll be sticking with ruxolitinib and we'll be kind of having them use it 2 days a week, 3 days a week. I imagine there will be some protocol in the future about that.
Okay, perfect. So
Yeah.
more to come on that.
Yeah.
All right. You spoke about oral medications for alopecia areata.
Yes.
Tell me how you use prednisone in patients with this condition.
Sometimes patients have really significant alopecia areata, but they're not ready to consider something like a JAK inhibitor. Maybe because of their age, or maybe just because they're still kind of absorbing all of this information and they're just kind of mulling it over. A useful alternative, if like topicals aren't working and I don't do a lot of intralesional injections in kids for obvious reasons, the pulse prednisone and low dose minoxidil approach can be a nice in between where you realize and appreciate topicals aren't working or there's simply too much alopecia areata to consider that practically. But the family isn't ready to jump into a treatment like a JAK. So what I do is I have them pulse prednisone. I use prednisone. Other people out there might use dexamethasone, but I was trained to do pred. And I do it 5 milligrams per kilogram, 1 weekend a month, half on Saturday, half on Sunday. So it's just 1 weekend a month that they're doing it. Most kids sail right on through it. It's like they're not taking anything at all. They don't feel any different.
You give them the pill or liquid.
Depending on their age and preference. Both taste horrible.
I know. The liquid, when I was an ER nurse, they would vomit on me all the time.
Yes. It tastes bad. And even the pill tastes bad. But at least with the pill, there's like less of it, because with the liquid, there's more volume. So patient preference, but I do tell them that it tastes bad. And so we do 5 mg per kg, 1 weekend a month, half on Saturday, half on Sunday. Most kids sail right on through. Small percentage of kids feel hyper. Small percentage of kids feel fluish. Most kids feel fine. And then I also have them take low dose oral minoxidil, depending on their age. So if it's a littler kid, like a 3 to 10-year-old, I'd probably do a quarter pill of the 2.5 milligram pills, a quarter pill Monday, Wednesday, Friday.
Okay.
If they are older, 10 and up, I'd probably do a quarter pill every day. But a lot of it is a nuanced thing, even regardless of age, how much do they weigh, and all of those things factor in. But I'll frequently use them in combination. The pulse prednisone to tell the immune system, stop attacking those hair follicles, and then the minoxidil to say, hey, hair follicles, let's grow big and strong.
Love it.
Yeah.
What scores do you use for measuring severity in alopecia areata? And is there a score that takes into consideration psychosocial impact?
So in the clinic, I use SALT scores mostly because that's what was used in the trials and that's what insurance companies are wanting from us in our documentation. And so I do SALT scores. In terms of impact, it's so huge. The alopecia areata, anytime you see a patient and family dealing with alopecia areata, there's a lot of crying. There's a lot of crying. And if I know that that's the patient who's coming in, I will try to accommodate, have it scheduled at like the last one of the morning or the last one of the day, just so the family doesn't feel rushed because I get it. I get it. and they need to feel their feels and they need to get it out. And really, in the dermatologist's office, that's the only place to really do it. Where else can you just kind of let it rip, and where people are around you that understand the condition and are there to help? So there's a lot of crying in the management of atopic of alopecia areata. But the cool thing is, when it gets better, there's so many happy tears. It's like the most joyful thing. Like when you walk in a room of a patient with alopecia areata, that first visit when like all their hair is coming back, or like you walk in and everything looks like normal from a distance, it's like the best feeling in the whole world.
Isn't it the closest thing to magic that
It
we can do?
is. It really, really is. It's so wonderful. Um, I always tell clinicians treating alopecia areata with oral JAK inhibitors will change your life. Like it truly does. It's so career affirming and just truly magical. And so those moments are really, really special.
Isn't it funny the first couple people you put on it, you try to act cool, like, yeah, this is totally what I was
Yeah.
expecting, but
Yeah.
meanwhile, you're like doing the happy dance inside.
Yes, yes, yes. I kind of let my emotions show no matter what. I still remember the first patient that I treated with an oral jack. I still see her today. She's an adult. Her name's Brooke, and she's wonderful and special and amazing. And I still remember seeing her that day when her hair was back. And oh, such a wonderful
I
feeling.
remember my first patient too. I couldn't believe it.
Yes. Oh,
All right, talk a little bit about pregnancy considerations for our alopecia areata patients when you're considering an oral jack.
yeah. So we don't want patients to get pregnant on oral JAK inhibitors. And so it's important to talk about. Yeah.
Are they teratogenic?
We just don't know.
Okay.
And I think there's reason to believe that they could be.
Okay.
And so with that knowledge, it's like, why even? And in general, I think we're all so careful and cautious around pregnancy, which is totally appropriate.
Mhm.
That's a very special, important time. And we want to make sure everything goes incredibly normally for that family.
Absolutely.
If I'm seeing a woman of childbearing potential and we're considering an oral JAK for alopecia areata or for atopic dermatitis, I am going to talk to her about her family planning goals, what's on the agenda, what's she thinking about. If she has atopic dermatitis and she says, I just got married, but we're not planning on having kids for 3 to 5 years, I'm comfortable going ahead and getting her started on the JAK inhibitor and just letting her know we're going to want to stop this once you start planning to start your family. And worst case scenario, I think it probably is okay if the medicine is stopped when the pregnancy test turns positive. I think that's not as desirable, but I think it would be okay. These medicines are out of our system so quickly that I think that would be all right. I would prefer to have them stop when they're anticipating trying to start a family. Alopecia areata is kind of a different ballgame because if I see a patient and she tells me, oh, in maybe a year or two, I think I'm going to try to have a baby. I would actually make the recommendation to wait on the oral JAK inhibitor until after she's had her family, because if we start her on it, she's going to be hitting kind of peak hair regrowth at probably a year. And then she's going to be thinking about starting her family, and we're going to need to take her off of it. And chances are the hair loss is going to recur. And that's just really hard psychologically. And then, meantime, she's trying to get pregnant and the hormones are going. And that's just not a good situation for anybody. So I think if people are thinking, oh, a year or two or even 3, maybe postponing treatment is the right way to go, trying some other treatment first. In those situations, I might even think about dupilumab. We
Mhm.
know that sometimes Dupi works for alopecia areata, sometimes it doesn't. There was a nice study that showed that if their baseline serum IgE was greater than 200, it had a good chance of working. So if I had a woman who was thinking, oh, a year or 2 or 3, I might try to get pregnant, well, let's do some labs. We could do baseline labs for the JAK just in case, and we could throw a serum IgE on there. And if it's greater than 200, I feel like that would be a really nice choice because I think most of us feel very comfortable with Dupi during pregnancy. We're about to get the results of the pregnancy registry that's been keeping track of all of these patients for the past 10 years. That would be an approach that I would feel comfortable doing in a woman who thought that her family planning goals were happening sooner rather than later.
Do you monitor IgE levels in patients on Dupi?
No,
Okay.
I don't do any blood work for Dupi.
Just the
Just in
IgE.
general, just IgE to know if they're a candidate or not.
Are you doing quantiferon gold for tuberculosis for your JAK patients?
Yes, at baseline. I don't repeat annually unless there's some risk factors like international travel or things like that, or a known family contact that, had tuberculosis. So I do at baseline because that's what you're supposed to do. Again, my patients do younger and are generally low risk, and then would only repeat if there were risk factors.
Okay, final question.
Mhm.
If you had a patient on an oral JAK
Mhm.
for whichever condition,
Mhm.
and then they decide to get pregnant, you stop it.
Mhm.
What are the chances later of them achieving the same success that they had before?
Excellent. Excellent. We have data from baricitinib from their withdrawal data that the patients who withdrew and had recurrence of their alopecia areata when the treatment was restarted, they recaptured beautifully.
Same course,
Mhm.
not longer or anything like
No,
that?
same
Okay.
course, but it's really hard, especially in females. When you're dealing with a male patient, their hair is inherently shorter. So if you have a break from your JAK inhibitor for whatever reason, intentional or unintentional, and you get a relapse of your alopecia areata, you get them back on the JAK 2 or 3 months, their hair's regrowing and it's almost caught up to
Mm.
their normal hair length. Whereas girls, they have a relapse. Meanwhile, their hair is at their shoulders or beyond, and it's going to take months or even greater than a year for everything to kind of catch up and look normal again. So, a relapse in a female patient, a much more difficult emotional thing than a potential relapse in a male patient.
All right. Any closing remarks? Anything you want to end with?
No, I mean, I would just say that we are living and experiencing some really exciting times in the world of dermatology, and we are able to help our patients deal with some really challenging skin diseases in such an extraordinary way. It's just a very special time.
Well, thank you so much. And
Yeah.
thanks to everybody for joining us.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.